talk on stable triple vessel disease strategies for management.
Good morning. Today's topic is made it slightly more clear that we are going to talk on revascularization in stable CAD. You know, after so many trials, the Courage trial and the Bari 2D trial, lot of discussion went on whether we should really treat these patients by intervention. Should we treat them medically only? Is medical management as good as interventional management in these patients? First slide, if you look at what the interventional cardiologist or a cardiac surgeon would ask is when revascularization is life-saving. Now here a lot of egos are involved. And you can see the biggest ego is that of a doctor. Previously it used to be a cardiac surgeon. Today it is an interventional cardiologist with that ego. When I do it, especially it is life-saving. So then the first question we have to ask is, which of the following is true? Does stents do not prevent death? CABG prevents death compared to stenting. All of the above, none of the above. Let us look at this. When does really stent save lives? Definitely in STEMI, you can see the red bar is for lysis and the gray bar is for PTCA. You can see that stents do save life in primary angioplasty and also in non-STEMI. But can we say this for stable CAD? Now stable angina, whenever we are looking at, has a very good prognosis. Therefore, we should answer the question whether what are the risks the patients with stable angina go through. What is the risk of mortality, the risk of MI and death and CHF, and what is the quality of life? And what are the options we have? Optimal medical treatment with PCI, or optimal medical treatment with CABG, or all the three. So let us look at the definition of stable CAD, the definition of stable CAD, not angina. If you look at the first trial that was done for stable CAD, it was the CAST trial, the European Cooperative trial, and the VA trial. That was done in late 80s, early 90s. And they defined stable CAD as all patients with class 1, class 2 stable angina. Also included stable post-myocardial infarction patients. Then the Courage trial defined these patients with stable CAD as class 1 to 3 stable angina, all stable post-myocardial infarction patients, and included all asymptomatic patients with a positive stress test. Then Bari 2D trial defined them as any patient who is going for an elective surgery or angioplasty in next 4 weeks. Included 9% of unstable angina patients, but relatively stable unstable angina patients. Therefore, basically stable CAD is not just stable angina. Stable angina, asymptomatic patients with positive stress tests, and also stable post-myocardial infarction patients. And if you look at the number of trials, so many have been done. Obviously, in 12 minutes, I cannot cover all of them, but I will try to go for the more recent trials and then give you some idea. But one has to bend or look at the trials that were done in late 80s and early 90s, because they were all stable CAD patients in whom CABG was compared to medical management. So whenever they compared bypass surgery to medical management. So they showed clearly that CABG bypass surgery improves survival in stable CAD patients if they have unprotected left main disease, VA cooperative trial, if they have triple vessel disease with decreased LV function CAST trial, or if they have two vessel disease with proximal LAD and a positive stress test, European cooperative trial. Therefore, these three trials definitely have shown that even in patients with stable CAD, you save lives if you do patients with significant coronary artery disease. Now came the Courage trial, and this was looking at whether optimal medical therapy is equal to revascularization, mainly PTCA. Here about 2,300 patients were randomized. Intensive medical therapy versus PTCA. Primary outcome was death plus MI, and secondary outcome was quality of life. Follow-up was 2.5 to 7 years. What did they show? No difference. 7-year follow-up, no difference between optimal medical therapy and angioplasty, telling that in stable patients doing angioplasty is no longer justified. But did they Did they come to that conclusion? Or can we come to that conclusion, or should we dissect the trial a little bit further? They also show that even myocardial infarction is same between optimal medical therapy and PCI. Therefore, we need to dissect the trial a little more and see what actually they are telling, is it correct or is it wrong. Now, before we go to that, let's look at BARI 2D trial. In BARI 2D trial, diabetic patients, what they did is, they divided patients into PTCA stratum and CABG stratum. Patients with PTCA stratum were randomized to PCI versus medical therapy. Patients with CABG stratum were randomized to CABG versus medical therapy. All 1:1 randomization. And what did they find? And if you look at, dissect the data in the BARI 2D, most of the patients with single vessel disease were given angioplasty. Most of the patients with triple vessel disease went for both CABG, 55%, 45% went for PTCA. And what did they find? In the PTCA stratum first, no difference in survival between medical management and angioplasty. And the CABG stratum, no difference in survival between bypass surgery and medical therapy. Now when you say like this, is it? Now let us look at myocardial infarctions. If you look at myocardial infarctions in the CABG, in the PTCA stratum, there was no difference between medical therapy and PTCA. But in patients who underwent bypass surgery, because majority of them were more severe disease, triple vessel disease patients, non-fatal MIs were less common in CABG patients than in medical therapy. Definitely non-fatal MIs were less and the difference was statistically significant. So therefore they said that if you do in BARI 2D trial, if you do CABG in patients with severe triple vessel disease, with stable CAD, you might reduce their MIs, but you don't improve their survival. Now, there is a lot of introspection we have to do about this trial. And then we dissect the trial. You find, if you see patients with optimal medical, these are all intention to treat trials. And if you look at number of patients who are randomized only to optimal medical therapy and followed for 4 years, how many patients required revascularization because they became unstable or they became very, very severely symptomatic and has to be taken back to the hospital and underwent PCI or CABG? 33% in COURAGE trial and 42% in BARI 2D trial. So are you correct in telling that optimal medical therapy is equal to revascularization in this group of patients when nearly half of the patients in 4 years require revascularization? And if you look at the BARI 2D trial, you can see the lower blue curve, dotted curve, is showing medical therapy patients who went for interventions. In the first year, as high as 19% of patients had to go for either PTCA or CABG when they were randomized to optimal medical therapy, and in 4 years, 42%. To say, very important that optimal medical therapy is not just optimal medical therapy. Optimal medical therapy in majority of these trials is optimal medical therapy with intervention whenever required. So intervention had to be done, and therefore you cannot discount and cannot tell definitely that intervention is not needed in stable patients. Intervention does help, and but only question is, does it improve the mortality? Well, the potential explanation is there is always a selection bias in all these trials. How do you, like for example, if a patient, 80-year-old patient comes to you with a positive stress test and he is asymptomatic, do you treat him the same way as a 45-year-old patient with chest pain and anterior wall ischemia? Definitely not. We treat them differently. But what happened in these trials? Initial entry was angiography. It was not symptoms or stress test. Therefore, it is not correct to say that it doesn't save lives. Therefore, in summary, I would say that stable patients, if they have triple vessel disease with LV dysfunction, if they have left main disease, or if they have two vessel disease with proximal LAD and positive stress test, bypass surgery has shown superior survival to medical therapy. The second point is significant proportions of patients on optimal medical therapy need revascularization on follow-up. Therefore, you cannot say that patients on optimal medical therapy, you can avoid revascularization. And most important conclusion is patients with severe lesions may benefit from revascularization. Is it true that if you treat severe lesions, does it reduce revascularization? This question is answered by this trial, FAME trial. What is FAME trial? FAME 2 trial. This is a trial in which they are looking at FFR. And if you ask me today, what is the best way to demonstrate ischemia in a patient with a vessel with a stenosis? The best way used to be the nuclear stress test. But today, we are one step ahead, and FFR is probably the best way to demonstrate ischemia. If you have FFR less than 0.80, that means that lesion is extremely critical and it is physiologically reducing blood supply in that vessel. And therefore, it is very important to look at this trial. In this trial, what they did, they took about 28 centers, large trial in which they took patients with stable CAD, 1, 2 or 3 vessel disease, and they were randomized depending on their FFR. If the FFR is more than 0.80, obviously lesion is not significant. All of them went for medical therapy. This is not the randomization. The randomization is in patients who have FFR less than 0.80. And they were randomized, 1:1 randomization, to either stent or optimal medical therapy. And what happened? When they did, this is a 5-year trial. This is a large trial. And after 1 year, after 1.5 years of recruitment of the trial, that trial was stopped by Data Safety and Monitoring Board. Another one point about the trial is look at primary endpoints. Primary endpoints is not just myocardial infarction or death, but the last one is very important. Unplanned hospitalization leading to urgent revascularization. So those randomized to optimal medical therapy or stenting, if they required an unplanned intervention, when they come for urgent hospital admission and intervention, that means if they have become unstable and they require immediate intervention, then that is also a primary endpoint. And what did they find? That the Data Safety and Monitoring Board stopped recruitment after 1,200 patients. That is because they felt it is no longer ethical to randomize patients with FFR less than 0.80 to medical treatment, because majority of the patients who are on medical treatment with FFR less than 0.80 were readmitted, urgent hospital readmission with urgent intervention. That is equivalent to MI and death in a patient with a stable CAD. Therefore, one cannot say that the trial is still going on. We don't have the full data, but whatever data available till now, it is this, that if the patients were randomized to optimal medical therapy with an FFR less than 0.80, all of them required urgent, or most of them required urgent intervention. As high as more than 30% of patients required urgent intervention in less than a year. So that is a very important message that this trial has given, and therefore it is no longer tenable to say that according to Courage trial or Bari 2 trial, stable patients need not require intervention. If they have ischemia, if they have FFR less than 0.80, I think we are justified in intervening. Therefore, what are the conclusions? These are my personal conclusions. Never forget, because majority of cardiologists nowadays are all interventional. So better not to forget optimal medical therapy. It's very important. And second is, if patient is symptomatic, let us treat the patient. If the patient is asymptomatic, look for ischemia or look for viability before you intervene. Don't intervene if there is no ischemia, no viability. Because, I don't know, but FAME 1 trial has shown that if the FFR is more than 0.80 and you randomize the patient to stenting and medical therapy, if you follow medical therapy patients, re-intervention rate or event rate is less than 1% per year. Less than 1% per year. And if you intervene in them, the MACE rate is 12%. Therefore, it is not justified to intervene if there is no ischemia or if the FFR is more than 0.80. Intervene only if the FFR is less than 0.80. And we should avoid screening, aggressively looking in low-risk patients for ischemia. Stress test probably we should avoid if they are completely asymptomatic. We really don't know how to treat an asymptomatic patient. It's very difficult. Now, this is a controversial statement that lesion-specific based approach, FFR or pullback FFR, although invasive, has a potential to be more accurate than patient-based approach, that is non-invasive stress test. This we don't know. I must confess that in the future years to come, after the FAME 2 trial and the other trials come, probably we will be in a much better position to come to that conclusion, last conclusion. Thank you.
I congratulate Dr. Shailende Singh for nicely putting across the facts, and without wasting